They're known as retina achromic patch, or I call them RPE punched out lesions. You can see them better on fluorescein angiography, where you get window defect at the side of the achromic patch. Here's the same case, and you can see the achromic patch, but what else do you see in this picture? Well, you can see the 3 retinal astrocytic hamartomas sitting in front of the optic disc. In fact, the retinal achromic patch is so important, it's part of the diagnostic criteria for tuberous sclerosis complex. You'll notice a major feature of tuberous sclerosis is retinal astrocytic hamartoma, but a minor feature is retina achromic patch, or punched out spot. And to make the diagnosis of TSC, you need 2 major or 1 minor for definite diagnosis, and 1 major or 2 or more minor for possible diagnosis. So keep that in mind the next time you see a patient with tuberous sclerosis. Look for the astrocytic hamartoma and look for the achromic patch, the punched out lesion. This achromic patch is so important. We did a study where we looked at these achromic patches. We call them retinal pigment epithelial depigmented lesions with TSC. Published this in JAMA Ophthalmology. We indicated the most common eye finding with tuberous sclerosis is retinal astrocytic hamartoma. Other eye features include the eyelid angiofibroma, iris atrophy in some cases, coloboma, and then the retinal achromic patch. And this is often overlooked, and people have said this might be a flat astrocytic hamartoma, but we don't believe that. We believe it's just simply punched out RPE depigmentation. So we looked at 56 patients with tuberous sclerosis complex and found the achromic patch in 21%. And it was related to increased number of astrocytic hamartomas and more peripheral retinal astrocytic hamartomas. And it was also related to cognitive impairment, mental slowness, and related to seizures in our study. So I'm going to ask you a question again. Does the retinal astrocytic hamartoma or achromic patch have systemic correlation if you happen to see it as an ophthalmologist? In other words, can these be ominous findings? And the answer is yes. So a big study came out of Cleveland, Mary Arenell et al., and they looked at genotype-phenotype correlation of the retinal findings in tuberous sclerosis. They looked at over 900 patients from the Tuberous Sclerosis Alliance, and then 132 patients from their program. And they found 35% of these patients with TSC had astrocytic hamartoma, 12% had the achromic patch. And they found, like we found, if either lesion is present, the patient's at risk for brain tumor. These are called SEGA, S-E-G-A, subependymal giant cell astrocytoma of the brain. They're also at risk for renal angiomyolipoma, cognitive impairment like we found, and seizures like we found. So if you see these retinal findings, you should probably get the patient into a neurologist because they're at risk for seizures. So the retinal findings can imply greater risk for brain and kidney problems. So I sort of answered this question already. What layer does the retinal astrocytic hamartoma arise in? Well, it arises in the nerve fiber layer in every case. So Pichi et al. From Italy did a nice study on retinal astrocytic hamartoma classification. And he found these tumors fall into, he looked at 43 cases, and he proposed a classification based on spectral domain OCT. We later looked at our series, and we found that the astrocytic hamartoma arose from the nerve fiber layer in every case, and it had a moth-eaten appearance in over 90% of cases. So we looked at 47 eyes, and we found retinal layer of origin is nerve fiber layer. So here's our cases. You can see the astrocytic hamartoma in the left eye of patient 1 and in the right eye of patient 2. And if you look at the SD-OCT, the nerve fiber layer is expanded in the area of the astrocytic tumor. So that's in the nerve fiber layer. And here we're seeing the interesting case of what we call moth-eaten, optically empty cavities. These are so typical for retinal astrocytic hamartoma. 91% of cases show these. Now we do see moth-eaten, optically empty cavities with retinoblastoma, but that would be very rare. That's seen in retinoblastoma that has a cavitary appearance. But again, retinoblastoma arises deeper in the retina, not like the astrocytic hamartoma, which is superficial in the retina. And sometimes the moth-eaten cavities are related to calcification. You can see a calcified lesion, and sometimes they're just cavitation. It's just the tumor develops central cavities, not cysts. These aren't cysts. Cysts means you have epithelial lining within the astrocytic tumor. These are just cavities without epithelial lining. So it's related to either calcification or cavitation. And they're seen more frequently with large astrocytic hamartomas, and they tend to be larger cavities as the tumor gets bigger and bigger. Here's a tumor right near the optic disc. It's partially calcified, and you can see on the OCT how this has arisen, again, in the nerve fiber layer, and in this case, it pushed all the way down to touch the retinal pigment epithelium. So the management of retinal astrocytic hamartoma is observation in probably 99% of cases. When would we do PDT? Well, we would do PDT if the tumor looks like it's getting bigger, because sometimes that happens, or if it's starting to develop exudative retinal detachment, which occasionally happens. mTOR inhibition. So the development of any of the brain tumors in tuberous sclerosis occurs on the mTOR pathway. So children who have tuberous sclerosis and brain tumors, the current treatment now is to put them on rapamycin or sirolimus. These are mTOR blockers, and we've used it to treat a few cases of retinal astrocytic hamartomas that were enlarging. Jerry might have a comment about how commonly astrocytic hamartomas can actually grow, because sometimes they can grow very fast, but that would be, you would agree, probably less than 1% of them?
Yes, can I make a comment on that? Can you hear me on the microphone? Okay, we found out several years ago that in contrast to the teaching, it's always been taught to ophthalmologists that the retinal astrocytic hamartoma is a benign, almost never growing or slow growing lesion. Subsequently, we found 4 cases in our files which were different. These children were within 1 year of age. They were all diagnosed with retinoblastoma clinically.
Astrocytic hamartoma. They were diagnosed with astrocytic hamartoma.
They were diagnosed with retinoblastoma clinically, then sent to us with the diagnosis of retinoblastoma, but they had subtle signs of tuberous sclerosis. Mm-hmm. So we changed their diagnosis to tuberous sclerosis. And the new thing is that all 4 of these cases were so highly aggressive that they caused a total retinal detachment, pain, and they had to be enucleated. And the enucleated eye showed that it was, as expected, an astrocytoma. But these are interesting because they're exactly the same tumor that you see in patients with tuberous sclerosis in the brain. So we now know that these, in contrast to what you were taught in the past, can be highly aggressive in certain cases of tuberous sclerosis and can look like retinoblastoma. But they do have signs of tuberous sclerosis that should tip you off to the diagnosis. All of these patients had neovascular glaucoma and a giant tumor that filled the whole eye. One of them broke through the cornea and filled the orbit. So in contrast to what you were taught, these can occasionally be highly aggressive.
Thank you.
And we've published those in the literature if you want to look up the cases.
Yeah, I think nowadays, for those cases, we would probably use rapamycin or sirolimus if we see tumors that are growing. You can
When they're
them on
growing,
this
that would be
medication.
important. All of our cases had neovascular glaucoma and blind eyes, with tumors that filled half of the eye at least, so they all came to enucleation.
So enough about astrocytic hamartoma. The next tumor we'd like to talk about is retinoblastoma. This past year, we wrote in 2015, we wrote a report on the treatment of retinoblastoma in 2015. agreement and disagreement. And this came from 4 major centers around the world, from New York, from Philadelphia, from Lausanne, Switzerland, and from Buenos Aires in Argentina. And in this report, and these are the 4 authors, the city of brotherly love is also known as Philadelphia, and the Big Apple is known as New York. We indicated that we had substantial agreement and disagreement in how we treat, but we've all made huge progress, and we think this is perhaps the most successfully treated pediatric cancer when you consider leukemias and neuroblastomas and retinoblastoma. Retinoblastoma, at least in the developed world, has 98 to 99% survival. Let me just look at one thing here. We've also published a nice report on when to use the various types of chemotherapy: intravenous, intraarterial, periocular, and intravitreal chemotherapy, for those of you who are just getting started in the field of retinoblastoma management. And this kind of is a nice organized report that outlines how we use chemotherapy for retinoblastoma. I'll say a few words about how we treat retinoblastoma, at least in the United States. So we use 5 different protocols for retinoblastoma chemotherapy. Intravenous chemotherapy, that's known as chemoreduction, that's usually given for bilateral retinoblastoma. Intraarterial chemotherapy, that's given right into the ophthalmic artery, and that's used predominantly for unilateral retinoblastoma. Intravitreal chemotherapy is used only for active vitreous seeds. Subtenon's chemotherapy we used to use a lot before we had intraarterial, but nowadays we don't use it quite as much. It does have side effects that are unwanted. Side effects like fibrosis in the orbit and dysmotility, and it's even caused optic atrophy. So we don't use subtenon's chemotherapy anymore. And then we have high-risk retinoblastoma, which is treated with systemic chemotherapy to prevent metastatic disease. So it's an art and it's a science. It's not like a recipe. I can't tell you every patient is treated in one same way. There's a real art and science to delivering chemotherapy for retinoblastoma. Let's begin with intravenous chemotherapy, known as chemoreduction. This was first used in 1994 by the team at Moorfields in London, England. Then quickly, 3 centers in the United States recognized that this was being used, and Los Angeles, Philadelphia, and Toronto in Canada. We all started using intravenous chemotherapy, and we published in 1994, November, in JAMA Ophthalmology, our experience. All of us were using at least 3 agents: vincristine, etoposide, carboplatin. And the Philadelphia, where I'm from, regimen is to use these 3 agents for 6 cycles. So what we do is when a patient comes in with retinoblastoma, multifocal or bilateral, we give 6 cycles of chemoreduction to every patient. It doesn't matter if your tumor is this big or this big. Everybody gets 6 cycles of chemoreduction because each cycle plays upon the previous cycle and it causes complete tumor control. So this patient received 6 cycles. After 1 cycle, the tumor shrunk down, and it's at this point, when we're about to deliver cycle number 2, that we start with our focal consolidation. In this case, we gave consolidation with thermotherapy to each and every tumor. Each tumor received thermotherapy, and we spared the foveal region to protect the vision. Intraarterial chemotherapy, on the other hand, is generally used to treat unilateral retinoblastoma. We're very careful with this method because it can be very dangerous both to the eye and both to the child systemically. We always examine these children before they go to intraarterial chemotherapy. We mark the forehead with the medication and the dose that they will receive. This child's going to receive melphalan 5 milligrams, topotecan 1 milligram. Those are the 2 agents that we use, melphalan and topotecan. And we always mark the eye, and we place a clear tape called Tegaderm over our marking so that this does not get rubbed off or smeared as the child is going over to the place where he's to receive his intraarterial chemotherapy. Two different ways to deliver this. One is to directly catheterize the ophthalmic artery. Keep in mind you don't go into the artery, because if you go into the ophthalmic artery, you're likely to occlude the artery. You have to just face the catheter at the orifice of the artery and inject your chemotherapy so blood is allowed to rush in the artery along with your chemotherapy. That will reduce your amount of complications. The second way to deliver this is to use the balloon catheterization that occludes the internal carotid artery, and it allows the chemotherapy to secondarily go into the ophthalmic artery. We do use that technique in about 5% of our cases when we can't get close to the artery or the artery is too small to get our catheter right into the orifice. So we did a head-to-head comparison of intravenous chemotherapy versus intraarterial chemotherapy for unilateral retinoblastoma. Which method is better for children with unilateral retinoblastoma? We published this in the Asian Pacific Journal of Ophthalmology just this year. And what we found was, if you look at the classification of retinoblastoma, A, B, C, D, E, using intravenous chemotherapy in yellow, it does pretty well for unilateral group B and group C. It does less well for unilateral group D. But in blue, we see intraarterial chemotherapy. We can save 100% of group B eyes, 100% of group C eyes unilateral, and over 90% of group D eyes using intraarterial chemotherapy, generally 3 cycles. And that was significantly better compared to intravenous chemotherapy. So it outperforms intravenous chemotherapy. Here's an example. This is group D retinoblastoma with subretinal seeding. And after 2 doses of melphalan, the retina has completely resolved. The calcified scar is left in the macula. We have some RPE modeling, and that's from the chronic retinal detachment. But this is a great result. The eye is saved, and the child will have some peripheral vision. We even can use it in kids as young as 2 to 3 months of age. This was a large 2-month-old child with right eye with leukocoria. There's the tumor. And this is where you might be able to get by with minimal exposure intraarterial chemotherapy, because the tumor is localized with minimal seeding. And in that case, we got by with 2 doses of intraarterial chemotherapy, causing the tumor to calcify, regress, flattening the retina. And now we have papillomacular bundle, seems to be relatively well preserved, so this child may have some vision. It's at this point that we start to consider vision. So our first goal in these patients is to save their life, and next is to save their eye. And once we feel comfortable the eye is saved, then we start talking to the family about amblyopia patching, whether it be with patching or with atropine. This requires excellent catheterization skills. Of course, I don't do this. I have a neurosurgeon do this. Others have interventional neuroradiologists. Both are equally good at catheterizing up to the ophthalmic artery. And it also requires knowing when to use this and when not to use this. We still enucleate eyes, but not for a tumor this small. This is a small tumor. This is one that we would treat with intraarterial chemotherapy. Here's the other extreme for intraarterial chemotherapy, a 32-year-old man. He was discovered at age 30 to have retinoblastoma unilateral, treated elsewhere, and he had recurrence with this tumor in his left eye. So we gave intraarterial chemotherapy, and his tumor responded nicely. He required a few more treatments of other types of treatments with injection of the vitreous with chemotherapy, but he did very well, and we were able to protect the eye, save the eye, and protect his vision. But I can't give a talk on intraarterial chemotherapy without talking about complications. And there are complications that can be devastating. First of all, melphalan is a very powerful medication. If you give melphalan by mistake intravenously, don't ever make that mistake, it causes pancytopenia, and it can cause leukemia. It wipes out the bone marrow and can stimulate leukemia, and it leads to male infertility. Of course, we don't use it intravenously. We use it intraarterially. But if you give 7 or more cycles to males, it can induce infertility. We're publishing in Retina another complication that we have noticed with intraarterial chemotherapy that hasn't yet been talked about. Most of us have talked about the problems with intraarterial chemotherapy causing retinal vascular occlusion in the eye, but it can also lead to rhegmatogenous retinal detachment, because we're taking eyes that are horribly filled with retinoblastoma and trying to save them. And sometimes when the tumors resolve, it leaves empty spaces in the retina, and that leaves a hole in the retina, and leads to a rhegmatogenous detachment. And we found in our group of children that we've treated, 6% develop rhegmatogenous retinal detachment. And those at risk are older children who have very extensive vitreous seeding and diffuse involvement of the retina. And we think the cause is after the tumor responds, it leaves an atrophic hole after you have retinoblastoma regression. Sometimes it's related to a cryotherapy treatment, and sometimes it's related to a PVD. So here's an example of extensive endophytic massive retinoblastoma in a 4-year-old girl. Sure, we got the tumor completely under control. She had intraarterial and intravitreous chemotherapy. But right here, we had a series of retinal holes. You can see the lineup of the retinal holes, and she had shallow, persistent retinal detachment from those holes. Now, our retinal specialist could have gone in and flattened the retina, but he was not anxious to do that. Yes, we do retinal detachment repair after rhegmatogenous detachment in eyes with retinoblastoma, but it was too soon after her treatment for him to feel comfortable to go in. Here's another case. This is a child who had recurrence, so we used intraarterial chemotherapy to treat her recurrence. And after this tumor shrunk down, we had 1, 2, 3, 4 atrophic holes and chronic rhegmatogenous detachment. So it's something to keep in mind, and I wouldn't be overly anxious to go into these eyes because there could be a risk for recurrence and you may be dealing with bigger problems. I would actually maybe clean the vitreous with melphalan maybe once a week for 4 or 5 weeks, and then let your retinal surgeon go in and repair the retina. So enough about retinoblastoma. Let's
Carol,
move
can
on.
I ask you one quick question?
Sure.
A lot of talk has been done about pinealoblastomas occurring as the, quote, third eye in retinoblastoma. Do you have any comments on the method of treatment that might lessen the chances of a child getting a pinealoblastoma?
Yeah, not all of us agree on this, but most of the pediatric oncologists that I know of feel that giving systemic chemotherapy can reduce the risk for pinealoblastoma. Because if you look at the histopathology of pinealoblastoma, it looks exactly like retinoblastoma. And we believe that both have the same sensitivity to systemic chemotherapy, vincristine, etoposide, and carboplatin. And since we've been using systemic VEC in Philadelphia since 1994, that's 22 years now, we have not had any case, we've had only 2 cases of pinealoblastoma. So we think that it has dramatically reduced the number of brain tumors that we see. But we don't think that intraarterial chemotherapy will do the same because it's so focal just to the eye. So that's one of the benefits of using systemic chemotherapy. So we're going to move on to capillary hemangioma. The nomenclature for capillary hemangioma has been changed recently. It's no longer called that. It's called retinal hemangioblastoma. And I think all of you could detect retinal hemangioblastoma as a red-orange retinal mass, often with a dilated feeding artery and draining vein, with surrounding retinal exudation, subretinal fluid, and remote cystoid macular edema, and epiretinal membrane. This is one of the key tumors to the diagnosis of von Hippel-Lindau disease. If a patient has one retinal hemangioblastoma, their risk for having von Hippel-Lindau disease is inversely related to their age. By that I mean, the younger they are, the higher the risk. The older they are, the lower the risk. But if a patient has two hemangioblastomas, by definition, they have von Hippel-Lindau disease. Now, a nice study on VHL was done from the National Institute of Health in Bethesda, Maryland, by Wang and Emily Chu. And in this study, they looked at 335 patients with von Hippel-Lindau disease. That's a bigger cohort than anyone else has. And they found that the retinal hemangioblastoma in these patients with VHL was unilateral in 40%, bilateral in 60%, peripheral in 80%, juxtapapillary 15%, and the risks for poor vision included older age, juxtapapillary location, increasing number and size of tumors. Unfortunately, 13% of cases in their series needed enucleation for out-of-control hemangioblastoma. This one table, table number 3 in that paper, I thought was very telling. In this table, they looked at the impact of clinical features in the eye on ultimate vision. So if you look at the location of the hemangioblastoma, patients who had juxtapapillary tumor versus those that had peripheral tumor had a 3 times greater risk for bad vision. And those that had 5 or more peripheral tumors versus those with less than 5 tumors had a 8 times greater risk for poor vision. And those that had more than 1 quadrant of tumors versus less than 1 quadrant had a 27 times greater risk for poor vision. So you get the picture. Tumor near the disc, or multiple tumors, or more than 1 quadrant of tumors, the patient's at big risk for poor vision. This tumor really can wipe out vision, even though it should be a simple tumor to treat. So here's an example of a patient that might have good vision. Patient has a solitary peripheral tumor. It's in 1 quadrant. And in this case, we have many different ways to treat it. So ideally, with retinal hemangioblastoma, you want to catch the tumor when it's small. I'll ask Jerry. I have my own opinion, but I want to ask him his opinion. If a patient has a retinal hemangioblastoma, should you watch it, ever, or should you always treat them?
That's a debatable issue. If they have von Hippel-Lindau syndrome, they're much more aggressive and require more immediate treatment. We have a slight disagreement in our service that some of these that are very small and not causing any symptoms, with no history of VHL, you might be okay to watch those for a while as long as the reliable patient will come back and have you check them.
Okay.
Other people feel that any hemangioblastoma associated with von Hippel-Lindau should be treated. And they're probably right, because we've seen cases, as you well know, that went to no light perception, aggressive tumors that could not be controlled under all circumstances.
We have one case in our practice that went to NLPOU with really aggressive tumors. So I like to say, if I have a tumor that's outside the macula and the peripapillary region, I'm going to treat it. If it's in the macula or the peripapillary region, I will watch very carefully because I don't want to ruin the vision unnecessarily. Now, we have different ways to treat hemangioblastoma: laser, PDT, anti-VEGF, and plaque radiation. Anti-VEGF has been looked at the NIH in 2 reports, and it really doesn't do anything to the tumor. It might reduce the edema, but it doesn't touch the tumor. So in a case like this, with a peripheral tumor, we might treat this with photodynamic therapy. If you don't have PDT in your practice, you can use what I call the substitute for PDT. It's called ICG-enhanced thermoablation. You give ICG, and then you take a diode red laser, and you slowly cook the tumor, because the ICG makes the uptake higher. But PDT is a really nice way, and that's how we treated this tumor, with photodynamic therapy, and the tumor regressed nicely. A little bit of hemorrhage around it. You can see the exudate is drying up. That was a good response. Other tumors that are more peripheral, like this large tumor, you might want to treat with PDT or even plaque radiotherapy. That's what we used in this case, plaque radiotherapy, because this patient had near total retinal detachment, and that's pretty far out in the periphery to get PDT. So we put plaque radiation to an apex dose of 4,000 centigrade, and it causes the tumor to involute over time. And you can see regression of the tumor up here, a little bit of exudation left, but all that retinal detachment has resolved with plaque radiotherapy. Now, the name of the game with hemangioblastoma is to catch it as early as possible. Here I'm showing you a case of invisible hemangioblastoma. Now, how do I know one's there? Because the dad has retinal hemangioblastoma. So we screened his twins, and we found that both twins had asymptomatic tumors that we're not treating because they're not symptomatic. Can you see it in this picture? I'll circle where it is, right there. So I'll show you how we found it. We found it by looking, and then doing a fluorescein, and then doing an OCT. So that's invisible hemangioblastoma. This is one that we wouldn't treat, not affecting the patient, and we don't know. It may never affect the patient. I worry that it might, and if it does, we'll PDT it. Here's twin number 2, same father. This kid has a hemangioblastoma in both eyes. Now you can see the one in the left eye, right there. And it shows up on fluorescein angiography and easily seen on OCT. These are the tests you want to do for hemangioblastoma to pick it up. Fluorescein is wonderful for detection of hemangioblastoma. And I know many of you have Optos FA, best way to pick it up. But the right eye also had a tumor that we're watching. We treated the one in the left eye with PDT and laser photocoagulation. In the right eye, there it is. Can't see it, huh? But if you look at your fluorescein, you can see it. It's overhanging the optic nerve, but it's not causing exudation or macular changes on the OCT. Just watch it. If it happens to enlarge, I'm not sure what we're going to do. We'll probably do photodynamic therapy at risk for vision loss. So this is how we detect these little tiny tumors when there is a family history. And we publish this in retinal cases and brief reports, detection of invisible hemangioblastoma. Super early detection is key. If those tumors were in the periphery, they would have already been knocked off with laser or PDT by our team. We don't watch them when they're outside the macular region. Now keep in mind with hemangioblastoma, you have to remember these are patients that come with a body and they may have systemic associations. So the criteria for VHL, if the family history is positive, all you need is one retinal tumor to make the diagnosis, or one brain or visceral tumor. And if the family history is negative, you need 2 or more retinal tumors or brain tumors. So I like to look at this diagram and show you these are the 3 main sites for tumors in VHL. Eye, brain, adrenal, and renal area. And the tumor that usually presents first is the eye tumor. So it'll be you picking up a new proband with VHL. So the retinal lesions usually appear about mean age of 25 years, the brain lesions mean age of 30 years, and the renal lesions mean age of 37 years. And keep in mind the mean survival with VHL is 50 years of age. These patients tend to die from cerebellar hemangioblastoma or spinal cord hemangioblastoma that might have been missed. So you have to image the brain and spine. And renal cell carcinoma that may have been missed. So you have to image the kidney. And there are protocols that have been written that are available online and in chapters of books that tell you how often you should image these patients to check for VHL. There is a genotype-phenotype correlation with VHL, type 1 and type 2. Most patients with VHL, 80%, are type 1. They have a premature termination mutation. It's a deletion. And they don't get pheochromocytoma. This is how some people die too. They go into hypertensive crisis. Type 2 is only seen in 20% of cases. It's a missense mutation. pheochromocytoma runs in the family. So your geneticist will tell you which type of mutation your patient has, and based on that mutation, you know if the patient's at risk or not for pheochromocytoma. A lot of good papers have come out of the United Kingdom on the genotype-phenotype correlation. So what's the problem with VHL? We know the problem with retinoblastoma is the RB1 gene. The problem with VHL is this: hypoxia-inducible factor is out of control, and it stimulates the development of these vascular tumors throughout the body, in the brain, in the eye, and elsewhere in the body. And here's your HIF-alpha, hypoxia-inducible factor. But if you look at the pathway to the development of HIF, you see it's along the mTOR pathway, the same as tuberous sclerosis. And we have good medications, sirolimus. So some patients are now being treated with sirolimus for VHL. Keep that in mind if you have out-of-control disease. And it's also along the pathway of VEGF. And we have good medications systemically for VEGF, like Sutent, which is an anti-VEGF. That is one of the #1 ways to treat renal cell carcinoma in VHL, Sutent. And so if you have a patient out of control with eye disease, you might consider using Sutent. Okay, enough about the first two tumors. We're going to move on to...
Can I make a quick comment or question on the VHL? Many people in the world don't come from countries where you might have access to PDT or radiation. So one thing that we've used in the past, as you know, and you didn't mention it here, is the use of cryotherapy to treat selected cases, and we've had pretty good success in a lot of those. What do you feel are the indications today for cryotherapy in such cases?
So if you have a tumor that's anterior to the equator, we would probably use cryotherapy. If it's posterior to the equator, we'd probably use PDT as our treatment of choice, but if the baby's too young and you have to do it under anesthesia and you don't have PDT in the operating room, we would use laser photocoagulation. And what we do is we laser around the tumor for 3 rows and then find the artery and go right down the artery and close off the artery, but we don't touch the vein. Because if you laser the vein, you could lead to back of flow in the hemangioblastoma, and it might cause a vitreous hemorrhage. A lot of things you have to think of when you're treating these. Okay, so let's move on to another vascular tumor. And I think most of you in the audience may have seen vasoproliferative tumor. This is a fairly common tumor, retinal tumor in our practice. In my opinion, it's sort of a wastebasket of chronic inflammatory vascular scar in the back of the eye. There's 2 types of VPT. There's primary and secondary. Primary is far more common than secondary. That's what a VPT looks like. They're hard to see, but if you have a patient that has massive exudation and you think, does this patient have Coates disease, but they're like 50 years old, get a fluorescein and you might see there's a solitary mass that's leaking. That's a VPT, vasoproliferative tumor. It's hidden in the mass of exudation. It's ill-defined, minimally dilated vessels. This is not a hemangioblastoma. I can tell you that by looking at it. Why? Because the blood vessels aren't out of control dilated, and there's no discrete tumor there. Very ill-defined. So this is not associated with von Hippel-Lindau disease. It's kind of a chronic scarring process in the back of the eye. It tends to occur in the periphery. It leads to exudation in 72% of cases, associated commonly with subretinal fluid. Note that the exudation with VPT tends to start around the base of the VPT and march its way back to the macula. That's unlike hemangioblastoma. Hemangioblastoma usually starts with exudation in the macula, and then you identify the tumor after the patient has poor vision. These patients can get remote exudation and remote epiretinal membrane. So this is what a VPT classically looks like. Your VPT is right here. That's the vasoproliferative tumor, best seen on fluorescein angiography, and we have massive exudation marching back to the macula. You want to get this treated before this exudation gets any closer to the fovea. And in a case like this, where the tumor is so large and extensive, we would either use PDT or maybe low-dose plaque radiotherapy. So we published on a series of 334 cases of vasoproliferative tumors, but I have to admit, Jerry was the first to describe this tumor in a series of 12 cases back in the 1980s. Since then, there have been several reports on this tumor and various features. In this big series that we recently did, we found the secondary tumors, primary and secondary. The secondary tumors were seen in eyes most often with pars planitis or retinitis pigmentosa, 50% of the cases. Rare causes are chronic scarring conditions like toxo-P, toxo-C, chronic RD Coats disease. So if I see a patient that has bilateral vasoproliferative tumor, the first thing I think of is scleral depressed to look for pars planitis, and then get an ERG to look for retinitis pigmentosa. The secondary tumors tend to be bilateral, multiple, large, occur at a younger age, and patients have poor vision compared to the primary. And these were all significant factors. So here's a plate of primary VPT. Hard to see, but there they are. I circle the VPTs for you. And again, you're going to find them when you do a fluorescein angiogram. Like again, wide-angle optos, great for detecting this. Here are secondary VPT. Retinitis pigmentosa, post-retinal detachment, retinopathy of prematurity, pars planitis. Now, how do I know these are VPT? Because the patients usually have massive focal exudation. It's got to come from something. And so we look for Coats disease or a vasoproliferative tumor. They're kind of along the same spectrum. So here's one that we treated. We have treatment we can use. We can watch them if they're not leaking, but I usually don't like to do that unless it's a real reliable patient. Laser, cryo, PDT, plaque. Well, if I can treat it with cryotherapy, this is one anterior to the equator, and we treated this with cryotherapy like that, double freeze-thaw cryotherapy, and you can see the scar is all fibrosed on the right, and the detachment is nearly completely settled. Here's one that's fairly large, and this was treated with photodynamic therapy. And this patient had 2 or 3 spots of PDT, treating it like that, and you can see follow-up of PDT shows resolution of the exudation and a white fibrous scar at the site. So keep this in mind when you see this marching exudation back to the macula, you might be dealing with vasoproliferative tumor. Now, not everyone likes that term, vasoproliferative tumor. I think it's here to stay. Some people like to call these reactive retinal astrocytic tumors. But I think the terminology is a little bit confusing. You can read this article by Gross-Nicholas et al. We argued back in a letter to the editor that we think the term vasoproliferative tumor is very descriptive because they are vascular and they leak like a vascular tumor would leak. Okay, let's move
Carol,
down.
just one quick point out. When we reported the original 12 cases, we had a very specific description of these, and we wanted to use the term vasoproliferative tumor, but the reviewer of the journal would not let us use that. They said use the term presumed acquired retinal hemangioma. And the term that we coined then was not perpetuated, and now everybody that writes an article on it never finds our article. So if any of you write an article on the subject, please look up our 12 cases initially and quote it. Thank you.
Okay, next thing I'd like to talk about, another retinal tumor, is SCRAP. SCRAP, standing for solitary circumscribed retinal astrocytic proliferation. Other than Dr. Faruda, has anyone seen a case of this in the audience?
Show the picture first.
Dr. Rishi. Faruda, have you ever seen it? You've seen a case of this. This is something that once you see this, when I show you pictures, you'll never forget it. It looks like a retina pearl, a classic retina pearl. But it's not like the pearls you see in the periphery of the retina. This is a large, solitary pearl from the shores of Hyderabad, India. Right, Rishi? Anyways, it's a white tumor. It looks like it's in the inner retina. There's no feeder vessels going up to it. Has a very typical appearance, pearl white retinal mass. The initial description was by Jerry and our team, where we coined the term presumed solitary circumscribed retinal astrocytic proliferation. In this series, we had 7 cases. If you look carefully at these, again, it looks like a round pearl. You'll always find a little bit of RPE loss surrounding. And we initially didn't really know what that meant because we published this in the era of time domain OCT. So we didn't have good OCTs. Some people say, well, it looks like retinal astrocytic hamartoma, but really it doesn't because there's no traction, and astrocytic hamartoma has traction. It looks like astrocytoma. No, retinal astrocytoma has a more vague yellow-white look, and it causes exudation. This is not retinoblastoma. This is too white for retinoblastoma, and there's no theater vessels. And this is not RPE fibrous metaplasia, because that would be deep to the retina. So we didn't really know how this tumor happened. But that's why we coined a new term for SCRAP. It's a pearl white retinal astrocytic proliferation. So now we have good spectral domain OCT of SCRAP. Compared to astrocytic hamartoma that arises in the nerve fiber labor and gives you cavities. SCRAP doesn't. SCRAP, this is another case. This case was from San Francisco. And in this case, there's the white tumor, looks like a pearl, like the case I just showed you. And if you look carefully at the OCT, you're going to see this tumor actually arises maybe from the RPE in the outer retina. And I'm going to show you that in more high power. So astrocytic is nerve fiber layer. This is deep to the retina. And look at that. That's the SCRAP. So we think it could even be RPE fibrous metaplasia into nodular fibrous metaplasia in the back of the eye. Hence, maybe that's why they have a little bit of RPE loss surrounding, because it might be a primary RPE tumor, we don't know. But we did publish this in the journal Retina. Solitary circumscribed pearl white retinal mass, so-called retinal astrocytic proliferation, resides in deep retina or maybe beneath the retina. And we had 4 cases in that series. They all looked the same, and they all arose in the outer retina on SD-OCT.
Carol, can I make a quick comment on that?
Yeah.
When we wrote the first paper on this, we called it SCRAP, and we thought it was a great article, but many of our dear colleagues in retina decided to drop the S and just call it crap. And so we're still fighting that battle.
So that's making this course R-rated. We were trying to keep it PG. Okay. Anyways, so the next series of tumors we're going to talk about are the RPE tumors. These are actually among my favorite. There's a number of RPE tumors. Congenital hypertrophy of the RPE. Everyone's seen that, right? You all know what that looks like, but we're going to tell you some new things. Combined hamartoma of the RPE. I really don't think it's an RPE tumor, but it's under the RPE umbrella. Congenital simple hamartoma of the RPE, and torpedo maculopathy, which really isn't even a tumor, but it falls under the tumor section. Okay, so these are the RPE tumors we're going to talk about. So let's begin with chirpy. It takes only a millisecond to make the diagnosis of chirpy. We wrote a paper on over 300 cases of chirpy, just to look at what is this condition and what happens to patients with chirpy. So chirpy can show subtle flat enlargement over a long period of time, like 10 years, in nearly every case. It gets bigger over time. So you've got to keep a watch on these patients, maybe check them once every year or 2. Some people feel this is a low-grade neoplasm. It's a neoplasm of the RPE that slowly gets bigger and bigger. And why do we say that? Well, because it can develop into adenoma and adenocarcinoma in less than 1% of cases. 2 times a year in our practice, we see a patient who's had classic chirpy that develops a nodule, and the nodule proves to be adenoma or adenocarcinoma. So some people feel that this slow enlargement of chirpy over time might suggest it's a low-grade neoplasm. So here's a plate of chirpy. Top plate shows slow enlargement over 8 years. Thank God this tumor is out in the periphery. Because if it's near the macula and it slowly enlarges through the fovea, vision drops. Because it wipes out the photoreceptors. Increased lacunae here in the middle plate over 8 years. And then here's one, chirpy, that had a little bit of thickening here, and over 2 years developed this nodule which was elevated, 3 millimeters in thickness, with exudative retinopathy, classic for adenoma of the RPE. That was adenoma of the RPE arising from chirpy. So chirpy should be followed yearly. I don't worry patients. I tell them there's a 99% chance nothing's going to happen. So what have we found